name is Crystal Wright. I'm a nurse at Providence Portland on a cardiac respiratory unit on 2R, and this video is for the purpose of teaching other nurses how to assess and care for patients with a chest tube and what that's all about. So first off, I want to go over what a chest tube is. It's a tube that goes into the pleural space of the lung in here to create negative pressure to help lungs stay inflated and to promote drainage of fluid. They're used to treat several different things. They're used to treat pneumothorax, which is when a lung has deflated. I've got an image here I'm looking for on my computer. And here's just an x-ray. Oh, that's not going to work. Let me grab it this way. Here, a pneumothorax. And here's an x-ray, and you can see the little arrows are pointing to where the outline of the lung is. So part of that lung is not sealed to the chest wall. They're also used to treat tension pneumothoraxes, where you'll see there's a deviation of the trachea and everything over to one side, and there's a complete whiteout of one lung. It's completely deflated, and because of that, it's starting to pull everything to this side, so you can see it kind of pulling this way. They're used to treat hemothorax, which is blood in that pleural space. They're used to treat pleural effusions, which is when there's fluid in that pleural space that needs to be drained. They're used to treat chylothorax, which is a condition where lymph fluid is getting into that pleural space. They're used to treat penetrating chest trauma, which can be just surgery. When we do surgery, it's very much a chest trauma. You can see they're poking a hole in there and creating trauma, and so then they leave that chest tube in to help the lung stay inflated as the patient heals from surgery. And pleural empyema, which is an infection in the pleural space that has gotten there some way or another and needs to be cleaned out and drained out. There's a normal large bore chest tube, which will have a suture and look sort of like this. That's a normal chest tube, like a normal large bore chest tube going into a patient. There's also a pigtail chest tube drain that's used often for just draining air. These bigger ones are usually used to drain fluid, but a pigtail chest tube drain is often used to just drain air. It's less painful for the patient because it's much smaller. Here's an image of a pigtail. Sorry about this. Here's an image of a pigtail chest tube drain, much smaller, going into a patient. And you can use, there's a certain kind of dressing called a Stay-Fix dressing that you can use to help them keep from wobbling around. You can order them from supply. So this is a Stay-Fix dressing. And if you just order Stay-Fix, you can type it into Epic, or you can call materials and ask for Stay-Fix. If you just order that from supply, you can get those. They help keep them from wobbling around. Another type of chest tube that you might see is a Pleurix catheter. It's a little more unusual. It's put in surgically into the body and then left in. You can see, like a lot of times you'll just see this little dressing on your patient with it wrapped around under a tegaderm, and then you'll have to order a kit with these bottles and things to drain them out. The 2R charge nurse is often able to come and do that, or sometimes if you'll order the kit, the PA will do it for you. So just check with them and figure it out. And the patient will usually know how frequently they drain. they'll feel uncomfortable. We'll drain to symptoms. So we'll drain it when the patient starts feeling short of breath or feeling like they're having a harder time breathing, because there's more fluid in that space. It makes them harder for that to breathe. So we will drain for symptom management, and that's why they're put in and left in. Often it's a situation of cancer or something that's causing them to have these repeat effusions, and so we drain it for that. Heimlich valves are a one-way valve that attaches to a patient when they're having a persistent air leak. That's another unusual kind of thing that happens on the chest tube, and we put it in or put it on the tube after they've had a chest tube and it's not been healing. So the valve just looks like this, and it attaches to the tubing. You can see this patient's got tubing going around attaching here. This one is going the wrong direction. I don't know why they've left it up, except for maybe that patient had drainage. That's probably not the best. Usually when they have drainage, we want to wrap a gauze around the tip of that and put a rubber band on it. One thing about Heimlich valves is it's very important to never occlude the tip where the drainage is coming out. You never want to put anything occlusive over this, not a glove, not a bag, not anything that's going to seal, because it's important to let the air out because the patient has an air leak. So you have to let that air out so that lung can seal closed. So the importance of this is to not let air in. This little rubber part in here keeps the air from coming in, but it lets fluid and air out. So you can never do anything to like collect the fluid that would occlude this, like that would tape or close off the system. It has to be an open system. So you can put a washcloth over the tip of it, or you can put gauze over the tip of it, and teach the patient how to change that and how to keep it as clean as possible. But sometimes they are drippy. Occasionally when they're really drippy, the doctors will put in or put on some more unusual things. So you'll see something like this, or like a mini, teeny tiny looking chest tube that'll go on the tip of it. If there's lots of drainage that comes out, we'll do that instead. And they'll go home with those Heimlich valves for a week or two while they're waiting for that lung to seal closed and that air leak to stop. And then they'll get their tube out in the doctor's office at that point when they follow up with an appointment. There's teaching and paperwork on that we can have available. You can call us if you can't find it. And we have it, the thoracic team has it on their discharge teaching instructions. They'll often click and put it in there. So that's another more unusual one. I'm just checking to make sure I went over all the pieces. So the first thing with chest tubes is how to assess them. So you want to start at your chest tube insertion site. Adjust this so you can see. It's kind of funny, I'm sorry, but I'm at home and I can't come to you and I can't do this in person because of the COVID-19 stuff going on. So I've got my kid's stuffed animal that just has a zipper pouch on the back. So I've got a chest tube going into him. So that's just what we're going to use because it's what we have. So there's a tube going into your patient. There'll be a suture at the site. You want to look at this insertion site. You want to feel around. I know it's tender, but it's important to feel for crepitus. You might feel it on one side or the other. You might feel it up in their neck. You might feel it over here. You might feel it down low. So you just kind of want to feel all around, and you'll feel some of that with your stethoscope as you're listening to them, but also just feel right around that tube site where it goes in, and while you're looking at the incision, while you're looking at it going in. Crepitus feels sort of like Rice Krispies under the skin. It feels like a popping, crackling sensation of a little bit of stuff moving around. If there's a lot of crepitus, you might not feel or hear that. It might be really just big and puffy. And then you'll feel that around the edges of where that air has gotten to. And that's air under the skin. It dissipates with time. Tell the patients usually it's not something to worry about. The only time we really worry is if it starts to occlude the airway. You can push it and move it around. So if it gets to the airway, the patient can push it and move it. Or if it gets into their face and it bothers them with their eyes, they can kind of push and move, and then they'll be able to see again if they push it away from their eyes. It might kind of push back into that space. But usually there's nothing that's done about it. If it gets really bad, there can be interventions. They can go back to surgery. They can poke holes, which is crazy, and sometimes they'll stick IV catheters in there to keep the holes open for a little while to let the air seep out. But usually you won't see anything crazy like that. You'll just feel that little bit of Rice Krispie feeling under the skin for your patient. As you're assessing the site, you want to look for signs of infection. So this animal is infected. He is bright red, puffy. You don't want that. There's a little bit of redness right at where the suture goes in, like like you've seen with incisions that are fresh, that's normal. But if it like spreads, gets angry, beefy, red, starts having purulent drainage, those are signs of infection. You want to look for suture secure. You want to make sure it's secure. You don't want to tug on it, but you want to look right at the site and make sure the sutures are right there at the tube and that the tube is right there at the skin. You want to make sure you're not seeing any little holes in the tubing. Thoracic surgery will cut holes in the tube that they put in to drain multiple. It's a long tube. It's like yay long, like from here to here, going in here and going up and around up into here. And they're draining all of those areas, so there's little holes cut into the tubing. And if your tubing has slipped out part way, and you see a tube here with a hole sticking out of your patient, that's a problem. That's not okay. But that's something you need to check for. You need to check your tubing, you need to check your securements, you need to check all the little parts and make sure that they're connected, you know, that this is connected to the tube here and that it's all secure and that nothing's loose and that nothing's kinked. You don't want to like see a kink like this laying on the bed. That's going to prevent the negative pressure. It's like taking the chest tube out, basically. It's not providing any of that suction to the patient that helps keep their lung inflated, so it needs to not be kinked. You want to look at the stopcock on the tube if it has a stopcock. There's often a 3-way stopcock on the tube. I've got a picture of one here to show you. And you just want to make sure that it is open to the patient. So you want the stopcock to be off toward the 3rd port that way, and you want to make sure that that the fluid can run from this tube down and out this bigger tube here. There's also sometimes a stopcock somewhere else on the tube. I think our Oasis ones our Oasis ones don't usually have them, but sometimes there'll be a stopcock here on the chest tube. There'll be a thing that you can turn, and you want it to be turned in line with the tubing so that everything can flow through. You don't want anything turned out that way or that way. You want everything in line with the tubing. And one way to see is if you have any drainage in your tubing in a dependent loop, you just lift your tubing up like this and let it drain down into your canister. And as it's doing that, you can see that the tubing can drain from this part down into this part. So those are very important things to check and assess on your tubing while you're looking at it. And then from that point, then we want to look at our chest tube atrium. And you want to, we usually use this one that's called Oasis. Sometimes you'll see one that says Ocean. I'll show you a picture of it in a little bit, but the Ocean ones, instead of having this chamber with this orange accordion that will come out when the suction is on, they'll have a chamber right here of bubbling water that you can, it will bubble when you plug it in and not if you don't, and is up to a certain level based on the suction. But on this one, the suction is based on this dial here. There's a knob right here on the side. There it is. That you can turn to adjust the suction to the number. So this is a -10 section. Or -20 sections are the two most normal ones. Check your orders to see what they say and make sure your suction is turned to what the order says for the -20 or the -10. And then you need to plug this top blue right here into the suction canister into the wall. And that needs to be turned to low suction at like 70. It says on this tube if you're ever unsure. But just low suction, not high, not medium, just low suction, and then plug it into here, and then you'll see when it's plugged in that this accordion will come out, and that's tell you that the suction's plugged in. The orders can be kind of tricky. A lot of times the orders will say -20 H2O, that means suction. That -20 anything, the H2O does not mean water seal. The order will say the actual words water seal if they mean that chest tube to be to water seal and not to suction. Frequently after surgery, patients are to suction for a period of time and then it will come off and they will go to water seal. Sometimes they come out straight to water seal, so make sure you check your orders and make sure when you're assessing that you're assessing your tube, that this is where it says it should, that suction is plugged in or not plugged in, that the accordion is bellows are out if it ought to be if your patient's on suction, and that if it's the Ocean, which we rarely see, will have fluid that's to the right level and that it's bubbling to a gentle bubble if it's to section. This is the air leak chamber down here. You can see that there are numbers along here, and they determine the amount of volume of air leak that you'll see. So when your patient's off suction is the easiest time to check for an air leak. You'll look for bubbles in this chamber, and not just turbulence, like bubbles that pop at the top. And sometimes you'll see them when they just breathe, and sometimes you'll see them only when they cough. When you only see it with cough, we call that an intermittent air leak. And when you see it when they're just breathing, we call it a persistent or consistent or just air leak. Any air leak is a sign that the lung is not staying fully inflated, and is a sign that the chest tube is not ready to come out yet. And like I mentioned before, that might mean if your patient has that for several days and it's not improving, that they might get something like a Heimlich discharge instead of going home with the chest tube. But usually we tell the patients when they're asking, when do you think this will come out? You know, if they're having an air leak, we say, well, you know, this has to get better, and it has to not bubble in here when you cough for it to come out. You can also redirect those questions back to the doctors. So large air leak is when you see bubbles all the way over to these higher numbers, and a small air leak is when you see the bubbles just over here. Titling, sometimes when your patient's on water seal, not when they're on suction, you won't see it. You'll see the fluid in here go up and down as they breathe in and out. That's not, if you see it, you can chart it. If you don't see it, you don't chart it. There's not much else to that. It is informational, it is helpful to the doctors, but it's not something to worry about or to page about. Just checking really quickly on my notes to make sure I told you everything. If you had taken suction off, if your patient was on suction, if you've taken the suction off to check the air leak, make sure you put that back on after you check your air leak, because your patient needs to be on suction if they have it ordered to help their lungs heal and come back into place. There's lots of different kinds of drainage, and I put some pictures on my computer to help you determine what kind of drainage is what and what's okay and what's not. So I want to pull those up and show them to you. You may see bright red drainage, which is sanguineous drainage. Here's an image for you. This is dark, thick. It's opaque. You can't see through it. It's not usually expected, and it's usually something we need to page about. I'll go over quantities here in a little bit. This is serosanguineous drainage. You can see that you can sort of see through it. It's not opaque, but it's still reddish. This is normal. This is what's expected for chest tube drainage to see after surgery. This is purulent drainage. This is what we expect to see in a patient who has an infection. This one is white. It's kind of a weird whitish color. This is what you'll see if your patient has a chylothorax, which is that lymph fluid. It really does sort of look like milk coming out into their chest tube. It's also opaque and hard to see through. They'll be on some funky special diets and some other things if they have a chylothorax, because for some reason eating any kind of fat besides MCT oil causes this space to stay open and the lymph fluid to get in there. So, but that's rather unusual, and you can Google it and look it up. There's lots of information when you do that. You can see yellow or serous drainage coming out of a chest tube. That's a connection. Where did I have my serous drainage picture? Nope, maybe I don't have it. It's just like a yellow clearish drainage, and not opaque. Like if it's opaque, usually it's considered purulent and infected, if not sanguineous. So those are the kinds of drainage that you might see coming out of your tube. Usually with serous drainage, just because your patient has a pleural effusion, it's important. It's not important. Like if a lot of drainage comes out, it's not necessarily a big deal. So for numbers, let's go over numbers here on sanguineous drainage output. If you can see, let me get where I can see and you can see. Sanguineous drainage is rarely expected. Page the PA for greater than 100 mils per hour for 4 hours, or greater than 200 mils in 1 hour, or greater than 400 mils overall, or just if you're really concerned about this patient, they're becoming symptomatic, their blood pressure is dropping, any of those kinds of things. Can't get them weaned off of oxygen. And then the serous drainage, a variety of output is expected, serous sanguineous, depending on the procedure. Both are okay. If you're concerned, you can page the PA for output for greater than 500, but some pleural effusions will put out a large quantity in a shift, and it'll just be fine. When you're assessing your patient, make sure you're listening to their lung sounds. Get your stethoscope and listen. Front, and then on the back. If your patient has a hard time leaning forward, you can kind of just slip it behind their shoulder as you help them, like sit their bed up and slip your stethoscope back behind their shoulder and listen. But it's important to get to those bases and listen to your lung sounds. You might hear a pleural rub. It's sort of an abrasive sound, sort of sounds like rubber rubbing against each other. It might be sort of a squeak sound. If you hear that it's a pleural rub, you can chart that. Sometimes you'll hear an absent lung sound if they've had a prior lung surgery and had a lobe removed. If they've recently had a lobe removed, you'll probably hear what we call referred sound. It sounds rather echoey or like you're underwater. You can hear the sounds of the other parts of the lungs that you just heard in the space where they took that out, because it fills with fluid and then it sounds sort of echoey in there until it fills with scar tissue and closes the space up. You might hear coarse rhonchi. If they have a lot of fluid draining, you can hear all that fluid in their pleural space and you might hear that. You might hear coarse crackles, and that's usually a sign that they've got stuff they need to cough up. Your patient might cough up bright red blood in small quantities. That's expected, as long as it starts to get darker and dissipate over time and not become brighter red and in more quantities. It's not something to page about. We just tell them, that you had surgery in that space. It's normal for there to be little bits of blood in there that you need to cough out. Better out than staying in there, and so it's a good thing that you're coughing it out. Encourage them in that way. And then just diminished. You might hear diminished lung sounds. There's some specialty chest tube things that you should not do on your unit, and you should call a PA or a 2R nurse to help with. Like pleurodesis, you might hear that word thrown around when we try to adhere the lung open through the chest tube. A lot of times they do that through surgery, but sometimes we'll put something in a chest tube to try to pleurodese and stick that pleural space and lung together to seal and scar them together. So sometimes we'll put something in a chest tube for that. If you get orders for those things, like doxycycline per chest tube, or TPA alteplase in chest tube, that's not for pleurodesis, that's for TPA. That's to break up clots, like for a loculated pleural effusion, where a pleural effusion is in pockets, like here, all over in the lung. They need to break open those pockets. They'll have you put TPA, like the same that you put in an IV site, but in a higher quantity, and they'll order that to go in there. Don't do that yourself. The PA can do it, or a 2R charge nurse can do it. You can call the unit, or the PA can often work it out with us of when that'll happen and have us come out and do it. Try to, and remove a chest tube. Do not remove chest tubes. Thoracic team knows this. They won't, usually if a patient's not a 2R, they won't put in an order to remove a chest tube. They'll do it themselves. But if for some reason if that happens by accident, you get an order to remove a chest tube, don't do that. Call the PA, see if they can come and pull it out. But you should not be doing that if you're not trained. Only trained nurses can do that. There's some do's and don'ts with chest tube patients. Some of this is just normal stuff for surgery patients, and some of this is specific to chest tube patients. But do walk your patients 3 times a day. Check orders to make sure it's okay to remove them from suction to do this. And then just take your tube and take off suction. Go for a walk, and when you come back, make sure you plug them back into suction. Make sure you keep the canister down below the patient. You don't want your patient carrying their chest tube up here, up below the insertion. You want to have them carry it down low. It has this little thing on it that you can turn and have it sit so it doesn't tip. It has little hooks on it that you can use to hang it at the foot of the bed. So we usually use both the hooks and the thing to try to keep it from tipping. You don't want it to tip. But do walk your patients. If they don't have orders that it's okay to come off suction, say they have a really bad pneumothorax and the doctors want them to stay on continuous suction for 24 hours. We have a portable suction on 2R. You can order a portable suction. Or you can just walk them in the room, just march them back and forth from one end of the room to the other end of the room and back again. That's still walking. It's boring or walking, but still they need the walking to help them with recovery. Do keep the canister upright without tipping it. Don't freak out if you do tip it. It's not that big of a deal. These don't connect to each other, and it just means you have to do math to figure this out. But if for some reason it's too complex to figure it out, or it's tipped too many times, or if for some reason you have an ocean and these things did mix and you've got blue water in your blood and blood in your blue water, then most of our tubes have this quick connect piece right here where it goes in, and you can just push this and it comes right out. You'll need to clamp the tube, and you'll need to have your new atrium ready and then just switch out the atrium. And so it's not that hard to change out the atrium, so don't freak out if it tips. Just check it and then just mark every column where there's fluid. Mark this column, mark this column, mark this column. And then you just have to add up what comes above your marks for your output. In your charting, make sure you're charting the output. Make sure you're charting whether it's on suction or not. Make sure you're charting your patient's lung sounds that you assessed and heard. Make sure you're charting the sutures, securement. Make sure that you're charting, you know, that the suction is to orders or not, like that it's doing what it's ordered to be. Get your patient up to the chair for meals 3 times a day. Teach your patient to manage the tube themselves if you can. Teach them to keep it upright. And have them get into the chair themselves. If they're not independent in mobility, then go in and get them up every time for meals. It's really important for them to increase their mobility. That's the best part of their recovery. And if it hurts, don't let your patient sit on the bed and say, oh, it hurts too much. Can't move. Your patient needs to be able to cough, deep breathe, and move. And that's their pain control requirements. And if they don't meet those things, then they need more pain medicine. Page the doctor if you don't have enough. There usually is a lot of things available. Use the lidocaine patches. Use ice. Use the long acting and encourage the short acting. And there's often a scheduled short acting and a PRN short acting. Give them in between and make sure your patient is getting adequate pain control to be able to cough, deep breathe, and move. Often we tell patients that they're not going to get to their comfort function goal. They're not going to get to zero pain. But what we need them to do is be able to move, cough, and deep breathe to be able to recover well. Encourage your patients to shower. We want to leave that wound open. We don't want to leave a dressing on it and keep infection causing moisture near there. We want to open a shower, wash it off, pat it dry. That moisture helps loosen things and helps sore muscles, helps your patient to feel better. And it's totally fine to do that as long as you have orders for them to be okay to come off of suction to walk, then they can shower. Encourage your patients to just the same surgery stuff for patients. Like, just be careful and manage their nausea and go a little bit slowly. If it sounds good, usually they can eat it. But puking when you have a chest tube really hurts, and it's really hard to manage their pain without oral medicines. So we really want to try to keep their nausea controlled from the beginning. Leave your chest tube site and insertion site open, like I mentioned. Our surgeons prefer not to have a dressing on them. If there's a lot of drainage coming out, you can put a dressing on it. Just make sure you're changing it frequently. They don't want anything left on there that's going to cause infection. Encourage your patient to use their incident spirometer and have them, breathe in and evaluate. Watch them and watch how far it goes up. Make sure they're taking that slow, deep breath in and that they're not sending that little one off to the side, flying up to the top every time they do it. They want to go slow, marathon style, breathing in, like, not. So encourage them to do that. Evaluate them. Chart it several times during your shift. Or at least watch them several times during your shift, so you're making sure you're getting them to do that. Encourage your patient to allow you to wake them overnight for pain medicine. If a patient doesn't get pain medicine overnight, these tubes are incredibly painful. The surgery is really painful. They've received a numbing. They always do a nerve block when they do this because they can see the nerve right there where they are, and so they inject it really well with benzocaine. But then when that numbing wears off, and often it happens overnight, your patient wakes up in extreme pain. So we encourage them to take their pain medicine, at least the scheduled stuff, even if it's numb, and to get that on board before the numbing wears off. And take it, allow them to have you wake them overnight. Don't use CPAP. So these are the don'ts. Don't use CPAP or BiPAP with these patients unless you have a specific order from the thoracic team saying it's okay to do with the chest tube in. That positive pressure can cause there to be air leaks and keep the space open rather than seal closed like it should. Teach your patient, or don't put petroleum around the site to try to seal an air leak. It's dissolved tissue adhesive and cause sutures to come loose. Just put gauze and tegaderm around to try to close up those sites. Don't put any kind of closed system over a Heimlich valve. It can close them off, cause your patient to fill up with air. It's an emergency. Don't do that. Don't let your patient be lazy, like I said, and sit around. Make them get up and move. It's really important. Movement is what helps heal them. If they say it's too painful with the tube in to get up and move, find other things. Try the lidocaine patches. Give them the Tylenol. Give them the ibuprofen. Especially monitor their urine output if you're giving ibuprofen, FYI, and creatinine levels, because it can happen that that's a problem for the patient. I already said don't worry too much if this tips, and explained that. Patient teaching, teach them that it's really important to take walks. Teach them that it's really important to increase the length of their walks over time as they're able. And as they get home, this is something that they need to continue to do, and increase the frequency of their walks. Teach your patient, your mobility and patient, your independent mobility patient to be able to manage this and disconnect it so they can go on walks. Encourage your patients to take scheduled laxatives and stool softeners just like any other surgical patient. You don't want to be constipated with this. Remind them about pain medicines causing those kinds of problems. We mentioned again the goal with pain is to be able to move, deep breathe, and cough. Teach them about this. Remind them that they might not get to zero, but as long as they can move, deep breathe, and cough, those are the big important things. Teach them to call for signs of pneumothorax. So it can happen if the chest tube falls out. It can happen if the chest tube's still in and dislodged. If one of those little holes that I mentioned, if you see, comes out. It'll be a sudden, sometimes it's a sudden popping feeling, sometimes it's just sudden shortness of breath, sometimes it's feeling like they're not getting enough air, sometimes you see their respiratory rate go up significantly. You listen to their lung sounds, and if you hear a significant change with significant decrease on the side where the chest tube is, that's a sign probably that they're having a pneumothorax. You need to page the MD or PA and ask for a chest x-ray. They may need to go back onto suction if they've just gone to water seal. They may need to go up to a higher level of suction. They may ask you to turn the dial and turn this up to 30 or 40. They may need to go back to surgery. They may need their tube readjusted. But that's important to teach them and to have them call for. And especially after a chest tube's been removed, they need to call you for those things. Usually there is a half-tied stitch that remains in the patient, a purse string afterward. It's in, and they just tie it when they take the tube out to close the hole, and that comes out in the follow-up appointment, so let your patient know that's when that comes out, and that they might feel it there, and that sometimes they leave it rather long, so they might feel that. Teach them not to submerge themselves in water. Most rooms in the hospital don't have a bathtub, but I know we have a room that does, so don't let them do that. They're not even supposed to do it when they go home until after their follow-up appointment with their doctor, when they get confirmation that that's all sealed closed and not going to get water in there. When to call the doctor or PA. If your chest tube is draining more than 500 per shift and you're concerned that's new, that's a big change. If it's after they've just gotten a clot buster stuff in their lung, like TPA, like we talked about, that's normal, expected, that's okay. But if there's some big change that happens, if you're seeing sanguineous drainage, again, greater than 100 mils in an hour, 100 mils an hour for 4 hours, greater than 200 mils in 1 hour, or greater than 400 mils overall, I'll get you guys a sign that you can have to put up that you have to call about if you get those quantities of drainage, especially sanguineous drainage. It's usually not expected. Signs of respiratory distress. Patient's really struggling and getting worse. Call for signs of pneumothorax. We just went over that. Call for signs of internal bleeding. Say you see a big hematoma at the site, or you see your patient's getting really pale, or you can't wean your patient off of oxygen, and you see some other things, their blood pressure is starting to drop. All those things are signs that maybe your patient's like bleeding inside and not coming out in the tube, or not coming out around the tube, and call for that. Call if your chest tube comes out inadvertently. Usually, if you have available in the room sterile water, sterile saline, and a graduate container, you want to just stuff that into sterile water real quick, to keep that same amount of suction going, because you want, well, not this end, the end that's in the patient, but you want to keep that negative pressure going. If that's going to take you a long time to gather those supplies, just gather the supplies to clean it and stick it back together, and then call the doctor, because they need to order an x-ray and see what's happened and if it's working adequately. And if your chest tube just falls out, the whole thing just comes out of the patient, cover that site up with a 2x2 and a tegaderm, and call the doctor. And they probably need a chest x-ray and just see if they're okay with it out. Do a set of vitals, both cases. If it comes disconnected, or the other way, do a set of vitals, make sure your patient's not needing more oxygen, just watch them, monitor, give them what they need, to keep their vitals stable. And then also, just if pain or nausea is not controlled enough to move, deep breathe, cough with the available medicine, and you need more medicine. So I think that's most of it. You can always email me with your questions. You can call the 2-hour charge nurse with your questions. We often have time to just go over that with you. The PAs are really great about going over teaching with you too, but if we're available, you can call us. We're happy to help. I hope this helps you as you get chest tubes on other units, and thank you for helping care for these patients for us.